we move to the next session. It is management of STEMI in COVID era in India. To chair this session, we have Dr. Geevar, Zachariah, and Debdatta. You are there.
Good evening, everybody. It's a great pleasure for me to join this program once more this year. Thanks to Professor Go for making this informative program for us. My today's topic is management of STEMI in COVID era in India. Now, if we look at the burden of COVID, approximately 190 billion people have been affected worldwide, and the mortality has reached around 4 million. And India, it is around 31 million, and the mortality is approximately 4 lakh. Now, the exact statistics about STEMI we don't have, but various studies have reported the cardiac injury is occurring in up to 25% of the patients with this disease. As already mentioned by Professor Yadav, that cardiac injury in COVID can occur in many ways, particularly AMI, be it STEMI or NSTEMI, myocarditis, which often simulates ST elevation MI, and that needs an isolation. It can be cardiogenic shock, cardiomyopathy, coronary spasm, arrhythmia, and vascular thrombosis. Now, the major impact has been on acute cardiovascular care, especially the AMI patients. Now, how does it do the STEMI? COVID predisposing to STEMI, it actually binds to the ACE2 receptors. As we know, it mostly affects the lung. It can affect the other organs like liver, kidney, heart, blood vessels. The direct vascular injury, it causes plug disruption and thrombosis and endothelial dysfunction. This is rather less common, but the cytokine release, which occurs in the second week with a cytokine storm, often leads to severe inflammation, hemodynamic instability, and thereby a demand-supply mismatch causing ischemia. Now, the mortality in COVID, in the pre-existing cardiovascular disease, if somebody has, it causes severe disease and even death. The case fatality rate may increase in diabetics to about 7.3% and in cardiovascular disease to about 10.5%. Now, the mortality in STEMI, it occurs in about 33% of the patients compared to the non-COVID situation where it occurs only in 11% of the patients. Now, the predictors of the mortality, it is worldwide, including India, the patients who need intubation, shock, patients who are within hospital, they develop the STEMI, patients who are diabetic and who are elderly. And they all need a longer hospital stay or ICU stay. And it has been found that 1 in 5 patients with suspected STEMI do not have any culprit vessel on CAG, and these could be explained by the coronary spasm or myopericarditis, which is very frequent, and also it can be a stress-induced cardiomyopathy. As already mentioned, the type 2, that is a demand-supply mismatch occurring the second week, is more common compared to the type 1 AMI. The atherosclerotic plaque rupture is less common. Now, raised troponin, 18 to 23% of the patients may have, and it may not always be related to coronary artery disease, and frequently it is due to myopericarditis. Now, if we look at how the COVID pandemic has affected our acute cardiology care, first, there was redistribution of the beds and wards to dedicated COVID-19 units. That has affected the inpatient cardiology capacity. There has been cancellation of the elective works, and it has affected the hospital stay of the acute cardiology patients who were not having COVID. Secondly, the patient, suppose a patient with cardiogenic shock and AMI comes to us and we don't have an ICU open for him. The recovery of the CTPS people or the patients were also affected. Secondly, the troponin elevations occurring in 18 to 23% of the patients caused a false positive ACS calls for we cardiologists. And often there were some unnecessary thrombolysis. Secondly, third point was that the less ACS hospital admissions, as we all know, due to the non-availability of the transport, which is very true in our country, where we depend on the local transports, the fear of COVID of the patients, and the first contact with the medical personnel was also difficult. And finally, the healthcare workers, particularly in the cardiology sector, were much affected because of the close contact during transportation or echocardiography or during interventions. So the challenge is to revisit the present guideline of managing AMI and adapt it to the changed scenario of the COVID situation. Though my topic is on Indian guidelines, I have included 2 slides from ESC STEMI management. They are saying that deperfusion therapy should be considered within 12 hours of ST elevation in 2 contiguous legs. All patients should be considered COVID positive, and safety of the healthcare workers also they have insisted. What they have said is that from diagnosis, from first medical contact to deperfusion can be done within 120 minutes. It can be extended by another 60 minutes due to implementation of the protective measures. Target time, if not met, then fibrolysis can be done, and complete revascularization they have asked for rather than going for a stage procedure to make safe the healthcare workers, and they have asked for an LV angiogram rather than an echocardiography, again to avoid close contact with the patients. And COVID myopericarditis, suppose the patient presents with chest pain, significant ECG changes, and elevated cardiac enzymes, and if we see that there are no pre-existing cardiovascular risk factors, or the wall motion abnormality doesn't fit with a single arterial territory, and if we require, we can use the CT coronary angiography to rule out coronary artery disease, and this is very essential to rule out the myopericarditis. So we Indians, how do we deviate from the above guidelines and adapt to a further modified one? Now, suppose somebody develops STEMI outside hospital. We should prefer, rather fibrolysis is preferred in our country due to the limited availability of the cath lab. Now, I have a data from non-COVID era that shows the different registries have shown that 40 to 60% of the patients only underwent thrombolysis, and 1 to 14% of the patients had primary PCI. So if that is the situation in these difficult days, how do we manage to have PCI for all patients? Secondly, a patient who develops STEMI within hospital, suppose the patient is severely ill, having a severe COVID pneumonia, are we planning for emergency PCI? It would be wise to have a multidisciplinary team approach, go for a fibrolysis. That would be a better option. And secondly, to keep in our mind, the survival benefit of primary PCI over fibrolysis is small, only a 2% absolute risk reduction in the non-COVID patients. So in the COVID with a high mortality, things could be worse. And finally, for the field fibrolysis, we should go for a rescue PCI. Now with this idea that in 2020, the Indian Heart Journal has published a position statement or document on AMI care management. What they have said, we should screen the patients who had a history of travel, contact with the COVID-19 patients, or fever or shortness of breath. They isolated the patients of low clinical probability. They should go with the non-COVID guidelines. In the acute MI with confirmed or suspected patients, we should go for a primary PCI. It is preferred, and with necessary precaution and preparedness, keeping in mind the delay in the emergency medical service availability and transfer time to the proper PCI lab, which is not always feasible in our country, and secondly, significant risk of nosocomial infection for our healthcare workers. So the recommendations the Indian Cardiological Society has made is that hemodynamically unstable patient, primary PCI is ideal, especially if the COVID pneumonia is mild to moderate. Secondly, the PCI is desirable in failed thrombolysis and delayed presentation after 12 hours when the patient is still having chest pain. And these patients should have an isolated cath lab, minimum personnel, adequate PPE should be provided to them. Now, clinical decision to PCI should be a joint decision between cardiologist, clinician, and the patients. Now, regarding fibrolysis, as we all know that fibrolysis therapy provides rapid and easier reperfusion therapy and causing less staff exposure to infection. So thrombolysis is a prudent option, and especially in the hemodynamically stable patients. However, the patients who have a door to balloon time more than 60 to 90 minutes, or the STEMI is not anterior, here thrombolytic therapy is wiser, and bleeding risk is low is also to be seen. The patients who are on mechanical ventilation or high flow oxygen generating high aerosol, again, thrombolytic therapy is of choice. Now, another controversial statement I shouldn't say the controversial statement, it is a firm statement which has raised a controversy, is that patients who are thrombolized in the peripheral centers, The inter-institutional transfer has been discouraged in our guideline. Index facility should stabilize the patient, and we need not transfer the patient unless it is required, and if required, teleconsultation should be done. But in contradiction to this, in some of our articles, like in JAPI, it has been said that pharmacoinvasive approach has been considered in some centers in our country. Now, a few checklists of the medications, like fibrin-specific agents are to be preferred over thrombolysis. Above 75 years, half-dose tenecteplase should be given. Clopidogrel loading dose shouldn't be given. Dose reduction for enoxaparin. Aspirin and clopidogrel have been well discussed, but we do not have much data on prasugrel or ticagrelor. ACE inhibitors can be safely used. Amiodarone with HCQ-less, regular monitoring of the QT interval is required, as like the antiretroviral viral therapies. And heparin should be given for a duration of hospital stay up to 8 days or up to revascularization. So in conclusion, fibrolytic therapy is a wise option in Indian scenario. Primary PCI is reserved for hemodynamic instability, life-threatening arrhythmias in a background of mild to moderate pneumonia. Thrombolyzed stable patients may not be transferred from peripheral centers for further PCI if they are stable. Rescue PCI should always be considered for failed thrombolytic therapy. Myocarditis mimicking STEMI needs identification because unnecessary thrombolysis should be avoided, and adequate protection of the healthcare workers should be of prime importance. However, the debate can continue because SCI, SEC, SEP, the consensus is still for primary PCI, pharmacoinvasive approach if primary PCI is not feasible, and fibrolytic therapy, they have also asked for the lower risk patients like inferior wall MI or lateral MI without any hemodynamic compromise. Thank you.
Thank you, Dr. Jayanta, for a wonderful discussion on a very problematic subject. And as I can see, there are three basic areas when you are thinking about STEMI management in the COVID era. The three aspects are, one is the reduction in the acute MI admissions, which we showed in our last study of around 41,000 patients all over India in 187 hospitals. We showed that there is a 35% reduction in acute MI admission. And largely this was because of the problem of lockdown and difficulty to reach a hospital in time. So much so that the hospitals in the big cities suffered more than the smaller cities where the reduction in acute MI admission was not very prominent. That is one. The second aspect is the management of whether which reperfusion strategy to be used. All the Western guidelines say that if you have PPE kit and if you have all the facilities, go ahead because primary PCI is the best option for STEMI. However, in India, it is a heterogeneous country where the facilities differ from region to region, zone to zone, hospital to hospital. So unless we are very sure that we can offer primary PCI, if primary PCI still, even in India, should be the best choice of treatment in STEMI in terms of outcome and benefit. However, it has to be weighed against the facilities available, the options, the hospital. So it has to be a shared decision and each hospital can form a protocol. The problem is that many hospitals in India have different protocols. Some hospitals, like very large hospitals in Bangalore, they do routine fibrinolysis, not primary PCI, and then go for early coronary angiography and if required angioplasty. That is the pharmacoinvasive strategy. But some other hospitals triage the patients. They decide if it is anterior wall MI, go for primary PCA. If it is a young patient with MI, go for primary PCA. But all others do a pharmacoinvasive strategy. And some people routinely, irrespective of the nature, go for. So we are yet to evolve. We probably have logistic issues which vary from one place to the other. So each hospital and each region has to adapt and create a protocol suitable with their requirement, their facility, and their capabilities. That is what I think. Then the third, we are doing a study now, Dr. Santanu Guha, you remember, we are doing a prospective registry to to find out which is the strategy employed by the major hospitals in India, and we'll get the results in another 3 to 4 months' time. And the third problem I find is that what happens to these COVID positive STEMI patients, whether they do badly, as depicted by many of the previous speakers. COVID positive STEMI patients, they do very badly. The NACME registry shows that the mortality for COVID positive STEMI patients who happen to be COVID positive, the mortality is 33%. But we don't find that. Our experience of fellow cardiologists say that the large number of patients, in fact, some of the big hospitals say that around 10% of patients with STEMI admitted to their hospital, they have COVID positive. And still they are doing fairly well. Their mortality is still less than 5% or 8% when they do when the primary PCA or even pharmacoinvasive strategy. So probably the challenges in India are different. And I think we should adapt to our own requirement, our own capabilities, and considering all the logistic issues. Thank you.
Thank you, Dr. Geevar. Incidentally, he is a pioneer in this field and was instrumental in publishing quite a few articles relating to COVID and cardiovascular, different cardiovascular diseases, ACS, STEMI, etc. And it has been already published in Indian Heart Journal, and some ongoing registry is also going on. So thank you, Geevar.
Oh, thank you.
Thank you very much.